Live survey.
Right. Good morning, dear delegates and friends of e-Neo course on neonatology for office-based pediatricians. I welcome you all on this Sunday morning. And as always, we are starting right at 9 o'clock. Today is the 13th session of this e-Neo course, which is specifically designed for office-based pediatricians to update their knowledge in neonatology. As you can understand, up till now, we have been discussing very important but basic topics of neonatology. That's not essentially based for core neonatologists, but everybody, every pediatrician who is interested in doing some bit of neonatology. Today is 13th session, and we have two more sessions to go. Before I hand over the mic to Dr. Amit, a few words about this course. We know that this is 13th course and two more sessions will go. After that, we are planning to send a MCQ-based questionnaire on your email. So just make it sure that we have your emails at the secretariat. It must be there at the time of registration also. So we will send an email, and within 48 hours, you will be expected to answer back that MCQ-based questionnaire to us. Once we receive that, only the successful candidates will be allotted the e-Neo certificate for neonatology. Please disseminate this information to all your friends and colleagues. For today's session, we have Dr. Amit Khosla, who will be discussing on retinopathy of prematurity. Being the chairperson for this session also, I just introduced the topic. Eye examination, retinopathy of prematurity is very essential component of core neonatology. We have seen in recent past a lot of medical legal cases against neonatologists and pediatricians alike who failed to identify that baby, if not examined properly, can develop retinopathy of prematurity, which can lead to permanent loss of vision. There are a number of cases which have happened, and it's our responsibility to make it sure that the baby is examined by a trained ophthalmologist who is trained in indirect ophthalmoscopy and has been doing this ROP examination for a number of years before we send the patient home in the NICU as well as in follow-up. So now let me introduce Dr. Amit Khosla. Dr. Amit Khosla is a senior consultant, retina specialist, and a core neonatologist friend who has been doing ROP skinning in Gangaram Hospital for closer to 30 years. He was a pioneer in starting ROP program in our hospital, and we are very fortunate to have him. He, along with his team, takes care of all the newborns who are admitted in NICU, and is trained in doing all type of surgeries. I have seen him doing cryo. Now he does laser. He also does intravitreal injections, and he also takes care of these babies in follow-up, whether they develop complications, whether they develop refractory errors. So he takes care of all these babies follow-up till they become adolescents and adults. So with these words, I welcome Dr. Amit Khosla, a very dear colleague, a very thorough gentleman, and who will be dealing with the topic of retinopathy of prematurity. Now it is over to Dr. Amit Khosla.
Good morning, everybody. I hope you can see my slide. So, retinopathy of prematurity.
Yes, we can see your slide, Dr. Amit. You can go ahead.
Start moving forward. Yeah. So, about 5 lakh children are preterm in India who require ROP screening. 10 to 20% of these will develop ROP, and about 5,000 will require ROP treatment. India has about 800, I think, newborn units. So ROP is an indicator of the quality of care. Most newborns develop ROP due to poor quality newborn care, unrestricted oxygen usage, high incidence of infection, lack of awareness, and blood transfusion. So we need to integrate the ROP service and child health services. And screening is the first step in the ROP management. So basically, it is an ischemic retinopathy of the premature child. So in a normal child, the blood vessels grow from the disc in the 16th week of gestation, and they cover the whole retina in 40 weeks. So if the child is born before 34 weeks, part of the retina would not be vascularized. And sometimes the ischemia generated creates abnormal vessel generation and changes the direction of the vessel, causing to retinal detachment and thus leading to vision loss. So basically, the pathogenesis is that oxygen causes vasoconstriction and closure. So once the child is born, in about 2 to 4 weeks, this will happen. So continuous exposure of beyond 4 to 6 hours will cause vasospasm. So the first day of birth of a newborn child, if given unlimited oxygen without monitoring the oxygen, will lead to oxygen exposure. So the first 2 to 3 days management is very essential. As I mentioned, the initial vasoconstriction can last several minutes, and if the vasospasm lasts for more than 10 hours, then you will have an irreversible change. So the various chemicals which are released are the insulin growth factor and the vascular enteral growth factor, which help growth of the normal vessel. But excessive VEGF released by the ischemic retina will lead to abnormal vessel proliferation. And the same chemicals also cause in the body limited brain growth and necrotizing colitis. So it is the same pathology which is causing all these three problems in a preterm child. So we know that the epidemics occurred in the 40s in America. The oxygen restriction helped reduce the incidence of ROP, but then as you do better management, we have smaller children surviving. And then the third epidemic is occurring in the moderate to low income countries where unbridled oxygen and infection are the cause of ROP. So in the bigger babies, more than 28 weeks, it is more because of the poor quality of service. While if we have a ROP in about 24 to 28 week gestation child, that is not preventable, maybe on the long term. But at the moment, if you have a good nursery and you are doing state of the art management beyond 28 weeks, you can prevent majority of the ROP. So we classify the ROP based on the zone, the central zone. If it's vascularized and the zone 2, 3 are not vascularized, there's a maximum ischemia and the worst prognosis. So on the beginning, first examination, if the zone 2 is vascularized, the chances of side-threatening ROP are going to be limited. So we have classified ROP. First is this area is avascular. The vessel stop here, but there is no demarcation line. In the second, the stage 1, you have this demarcation line coming up. That is stage 1. Stage 2 is that this becomes elevated. There's a ridge formation. The vessel will now grow, but the ridge has come into the vitreous cavity. Stage 3, the vessels start growing over the ridge, causing a fibrovascular tissue formation, which can lead to retinal detachment. Stage 4, you have a retinal detachment in the periphery. And stage 5, you have a total retinal detachment. Now, which child is going to develop ROP? Depending on the vascular incompetence. If you have dilated vessels in the beginning, this child called plus disease are more likely, and you will have poor dilatation of the iris, you will have iris vessels engorgement, you will have vitreous haze. Now, these children are likely to go into very fast ROP. This plus disease, as I mentioned, this is a dilated vessel, tortuous vessel, which is plus. So with mild dilatation, it's called pre-plus. It is a subjective pattern for the ophthalmologist to decide. Now, we have a type of ROP called the aggressive posterior ROP, especially in zone 1, when the child has had excessive turbulent course, oxygen, transfusion, infection. You will find that the stages merge, 1, 2, 3, 4 stage merge, and suddenly you have a very aggressive disease that is called an APROP, aggressive posterior ROP. Now, these children require aggressive therapy, and we need to see the children within 4 weeks. This is an aggressive posterior ROP, and you see majority of the retina is not vascularized. Only part is vascularized. These are the very high risk children. This is avascular retina. Remember that these children, even if their ROP regresses, have a long-term sequelae. The growth of the eye is affected, and you may have myopia, strabismus squeeze, retinal detachment, glaucoma, cataract on the long term. And if not treated, it leads to sometimes just folds, retinal folds coming up with poor vision. See the traction coming up so that this becomes pulled to one side, and you may not have a retinal detachment, but you may have these children who come to us. If you ask them what happened, oh, we were preterm. The children were preterm, the parent will say. And the child is 15 years and with poor vision. So this is one disease which, if done screening, we can prevent blindness. So when to screen? I think 1 mahina, ya 28 दिन. That is the theme of the government is within 28 days of birth, a child should be screened, and that is very important. Sometimes the child is in the nursery and the doctor doesn't have a retinal surgeon come into the nursery and the child gets neglected. Please, just every child less than 2 kg, less than 34 weeks gestation needs an eye checkup within 28 days of birth. So ROP may not form by 32 weeks except for the AP-ROP. The median age for detection of stage 1 ROP is 34 weeks. And generally it peaks at 37. So whatever, if a child has a normal, you will find the treatable ROP at around 37 weeks. So even if you discharge the patient at 36, it's important that the eye checkup is not missed. And it is the mutual responsibility of the nursery, the pediatrician, and the ophthalmologist screening the nursery to educate the parent that examination is important. And sometimes even phone calls have to be made and followed up that they come for an eye checkup. The government guidelines say that 34 weeks and 2000 gram. Though in the West it is 1.5, in India 2000 gram. Sometimes we tend to see children more than 34, less than 2, especially those one with IUGR. And we tend to sometimes need to screen excessive children as per the guideline. But you can form your own guideline as per the nursery results. What are the risk factors? When you have a support system, cardiorespiratory, prolonged oxygen, respiratory distress syndrome, lung disease, hemorrhage, blood transfusion, sepsis, all these are risk factors. And one of the biggest risk factors, which now is said, is the poor postnatal weight gain. Please ensure that the child is having a good weight gain in the nursery. First 4 weeks, and then you need to examine every 2 weeks till 40 weeks of gestation, when the normal vasculature will complete. So once the ROP is formed, it takes 6 to 12 weeks to regress. 80% will regress spontaneously. So you may need to examine the child up till 50 weeks, 50 weeks of gestation. And if the child is ROP, we do a 3-day or a 7-day follow-up. So when the child is in the nursery, the best is to do the examination in the nursery, because the child is sick and will have difficulty in transporting the patient to the ophthalmology. If we use an indirect ophthalmoscope, it is a headlight which is put on the head, and using a magnifying glass of 20 diopter or 28, we examine the peripheral retina, and we use a speculum to open the eye. We put an aniseted drop, and we use depress the sclera to see the peripheral retina. And we document what zones are vascularized, does it have a plus disease, and we advise a 2-weekly follow-up. This is various speculums. This is the ophthalmoscope, and this is how we put a speculum and we depress and see. You can, as with experience, you can even without a speculum, experienced retinal surgeon can see. But in today's world, we need to document everything, and I think the speculum has become essential, so that the child becomes uncomfortable using a speculum. This is a laser ophthalmoscope, laser attached to the endophthalmoscope, where you do the laser. So we dilate with phenylephrine and tropicamide in the nursery. We dilute, so we now have 2.5%, we dilute the phenylephrine. And we put the drops at 10 to 15 minutes. The pupil dilates in about 30 minutes. If the pupil is not dilating, then remember it could be a plus disease. The screening is done by an ophthalmologist trained in ROP, though a retinal surgeon would be ideal, but the retinal surgeons are not available. So many comprehensive ophthalmologists have trained themselves in ROP. So you will have 3 levels of ophthalmologists. One ophthalmologist who can screen only, one ophthalmologist who can treat the ROP, and one group of retinal surgeons who do only ROP surgery. So that is a very specialized surgery. And the child, while screening, should not have hypothermia, should have been burped an hour before, because we don't want the child vomiting during examination. There will be some mild discomfort and pain, and you can give a sucrose for the child to make comfortable. We normally wash our hands, we wear gloves, we have separate instruments for examination. When we press the eye, the child may have bradycardia, so we are very careful to be monitoring the pulse rate of the child. So we examine the iris, we check the extent of the vascularization or any plus disease. So when the retina is fully vascularized and there's no, or the child has crossed 42 weeks and there has been no ROP, then we stop doing the follow-up. So initially we used to do cryo in the 90s, then laser came in. laser can be done just with topical anesthesia and sedation. Cryo had to be done under general anesthesia. And if the child develops a retinal detachment, then retinal surgery is done. Now, with the coming of the anti-vascular endothelial growth factors like Avastin, ranibizumab, we are able to treat with injections also, which are given into the vitreous cavity like diabetic retinopathy. But these injections only work for 4 to 6 weeks. So those patients who have laser therapy may have full regression, but those who are given injections will have a recurrence up till 60 weeks of gestation. So they need to be followed up. So what protocol majority of us do is that once the vascularization reaches the stage zone 3, we laser these patients who have been initially given injection. So a combination of injection and laser reduces the follow-up because it's very difficult to examine a child at 55 weeks. You may require anesthesia and sedation. As I mentioned, that 80% of the ROPs will regress spontaneously. Only those who reach the stage 2 plus or 3 require treatment. So the zone 2, 3, stage 1, 2 with plus disease. So currently laser is the standard treatment of ROP. But you have aggressive, laser takes about 4 to 6 days to start acting. If you have aggressive disease, zone 1, then anti-VEGF injection becomes the first line of treatment. Some people are giving, do not have facilities for laser, are giving injections, but those children will need to be followed up to 60 weeks of gestation because they can have a recurrence. So the zone 1 any disease in zone 1 needs to be treated. Zone 2, only if there's a plus disease we need to treat. And I mentioned laser is the first line of treatment. I won't go into details. Normally, we do it in the nursery under ECG and pulse monitoring. And the child, if has pain, will go to apnea. We stop the treatment and we put an IV line and keep the child 2 hours nil only before we start the laser. Follow-up is required weekly after laser. And retreatment, if the laser is not effective, we can either go for an injection or we can retreat the areas where the laser marks have not come up. This is how we examine the child. Is pre-laser. Once we do the laser, we burn the retina so that the vascular growth factor is not released from the retina. So this area will have a weak vision. So you will have a peripheral scotoma on your visual field for the peripheral retina. That's why in zone 1, we don't want too much of a scotoma. We do laser injection. And when the growth occurs to zone 3, we do a laser. So the long-term side effects of VEGF are not known, but generally one trial has shown it is safe. The anti-VEGF I mentioned is very fast acting. You get the result in 1 day. And you need to treat the laser. Less laser needs to be treated. But all children who have been lasered have a risk for myopia and astigmatism. Maybe in injections, there's a theory that the amount of myopia is less. The long-term follow-up, as I mentioned, is very important. This is a patient who was given injection late and had the fibrous membrane had started. If you give an injection when the fibrous membrane has started, you will have a retinal attachment with a very poor prognosis. The injection has to be given at the right time. If given late, it creates worse situation. And if you do not follow up the child, the ROP again comes up at 60 weeks. So the VEGF levels are there in the blood, which they said it may affect the brain growth. At the moment, there are no confirmed side effects of anti-VEGF. So our aim is to prevent the child from going to stage 4A, 4B or 5 when the retinal detachment occurs, which have even with surgery have very poor prognosis. Any surgery done in a child will cause cataract and glaucoma, and only mobile vision or just enough of 660 or 612. It won't get 612 or 690. The child has gone to stage 4, you're going to have poor prognosis. So I've already discussed this. Just the repetition. I'm sorry. So I just want to discuss that children who come to you in practice who have preterm, you need to evaluate them at 1 month from the due date. So preterm child milestone should be checked from the due date. 1 month they make eye contact with objects nearby. 2 months they show facial expression. 3 months they observe their hand while holding them close. 3 to 4 months they watch activity around them. 6 months they start to recognize their toys. So we tell the parents that if the child is not seeing or not smiling at 3 to 4 months, then you need to come back for fixation and neuro assessment, because 10% of the children who have ROP will have brain problems. They can have periventricular leukomalacia, which affects their vision. After all, 40% of the brain is required to do a visual analysis. So the human face is the ideal target at 3 to 4 months, and toys for older children. So the child should be able to fixate on your target, on the light or the torch, and follow it slowly. Each eye is tested separately. So I request all pediatricians to keep an ophthalmoscope to assess the visual reflexes. You can just at a distance hold a target and look into the eyes. These are special tests called preferential looking tests for children less than 1 year. This Cardiff test for children more than 1 year to 3 years, and we get a idea of the vision based on the eye movements. Beyond 3 years, you can do letter charts, and you can put up these charts in your clinic. And at 5 years, I request all pediatricians to have these vision charts in their clinic, so that children beyond 5, every child who comes checks their vision once in your clinic. You can have image charts for children who are not verbal. The squint is a very high risk in children who are preterm. 10% will develop squint because of the asymmetric growth of the eye and the brain. So always refer a child with poor vision, any difference in both eyes. And if you were to put a hand in front of the one eye and the child resists occlusion in one eye compared to the other, then that eye has a poor vision. So you can do a red reflex with your ophthalmoscope. But done at every visit, and you will find that this red reflex comes to the center of the pupil. If there's an unequal reflex or it's absent, then you need a eye evaluation. Sometimes in children, this is squint. You can see the reflex coming in the center. In this, the eye is turned in, esotropia, the reflex is outside. Eye is turned out, the reflex is here. Or the child eye is gone up, the reflex is here. So if the reflex is in the center, then the child doesn't have a permanent squint. It may be intermittent, but it's not permanent squint. What happens if the child has squint? One eye will dominate, the other eye will go into poor vision, will have amblyopia. Sometimes if you have a refractive error, both eyes may be amblyopic. So amblyopia is actually 6/12 and less vision in a 5-year-old child. The visual development is complete by 6 years of age. So all preterm should be handled till 5 years, then they can be managed on a regular basis. We patch eyes with better vision to help improve the vision of the eye with the poor vision. So vision assessment is required in these children. And you know that preterm children are with special needs. Some have behavioral problems, some have neurological issues. So you need to evaluate them much better. So you can, as I mentioned, you can just the eye closure, the response in children will come. If you go near, the eye should constrict. The child withdraws an object, move rapidly towards the child's face, the threat response is evaluated. So remember, inspection, equity, red reflex, and motility in all children who have been preterm. If not all children, but especially preterm, definitely. Now there's a terminology called cortical visual impairment. In these preterm children, you may have neurological issues, which may have cortical vision. The eye is normal, but the child cannot have has loss of visual acuity, field loss, contrast loss, oculomotor disabilities, agnosias, visual spatial difficulties, do not have a sense of 3D. Motion is problem. They can't assess motion videos, or they have visual inattention. The CVI is caused because of lack of blood, hydrocephalus, infections. All these cause cortical cerebral visual impairment. So seeing and vision is not the same. When we take what we take into an eye is a jumble. It is the brain which makes sense out of it. Whatever happens outside, it needs to be constructed in our mind. So the occipital cortex has the equity, field, and contrast. The temporal lobe has recognition, faces, objects, roots. The posterior parietal lobes have focused attention on object of interest. They map 3D mapping of the visual world. They plan visually guided body movements. So These are three different parts of the brain which are going to map the vision and use that data to help us move, recognize, and see things better. So three levels of higher fish function. The occipital lobe is the printer. The posterior parietal lobes are the mapper and the doers. Then the inferior temporal lobe is recognition, Google. It's Google for us. If you have occipital lobe, you have visual defect, clarity issues, and this thing. If you have ventral system, you have object agnosia, root agnosia. Or dorsal stream is affected, you will have impaired visual guided movement, poor visual attention. You cannot identify things and move. So the back of the brain serves visual recognition and visual guidance. The middle serves the language processing and body and sensation, and the front the intellect. So all these three are important. So when you have a child with a cerebral visual impairment, child seems to see well and sometimes not so well. You will not get the attention. So basically, I tell the parent that the child is seeing, it is like a jigsaw puzzle. Part of the puzzles are missing, and the child has to tilt the head, elevate the head, or do nystagmoid movement to have a full image of the vision. So it has to make use of other senses, the touch, the hearing, the sound to able to learn everything. So the child may have an eye-hand coordination, difficulty in recognizing people, difficulty in understanding language of facial expression, difficulty in seeing, moving, and judging things, distances. People getting oriented to new surrounding. They have low vision, and CVI is accompanied by cerebral palsy, for example. So they may have impaired intellect also, they may have impaired motor function also, and visual impairment. So you need to assess your child who comes to have been preterm, that is it just visual impairment, is it intellectual, motor, and you combine and then rehabilitate the child accordingly. So parents do not understand what CVI is. They say, yes, the child can see, holds the mobile phone, but when you go to school, then you find these problems of walking alone. So never fill these child's room with toys. You should have a single toy, single color wall. Do not confuse the child. You need to grow up. I keep saying that the brain is slower. So you have to give them a course of a class 10 child has to be given a class 1 child course. So you have to grow up the child. Like we tell all parents that mobile phones for children less than 2 years create confusion in the brain. The brain cannot evaluate a video, and you are showing YouTube to child of 1 year. That video confuses the brain. So you need to give only that much knowledge to a brain which it can test and analyze. So please diagnose, help. A lot of ophthalmologists do not know about CVI. I request Dr. Garg to have a CVI symposium, get ophthalmologists and neurologists on board so we can help manage these children better. So one thing I need to talk about the ROP, because we all are part of the ROP spectrum. How can we prevent? So the most important primary care is good quality neonatal and obstetric care. So children who are high risk should be delivered in nursery which have facility for CPAP, BiPAP, and not they are put onto oxygen, high flow oxygen in the first 24 hours. Secondary, every nursery should have, who deliver children less than 34 weeks, should have a screening program. Use the help of ophthalmologists near your hospitals and start a screening program. Tertiary is that if the child develops complication, how you treat it and how you rehabilitate the child. It is a unique disease which can be prevented by good neonatal practice. Only pediatric eye services require screening, telescreening to detect the disease. So you can, now cameras are coming in, but they are costly, but we will have them much more. But you can, now that telemedicine is legal, I can send a camera to your nursery for evaluation. The secondary prevention, infrastructure and facility for ROP screening and treatment, expertise for screening and management has to be built. We have to have a capacity building in our system for ROP awareness. Delhi may have good ROP setups, but in small towns, you may not have a surgeon who's ready to do ROP screening. So it is very taxing. It's physically taxing to do a intratophthalmos. It creates a backache for the ophthalmologist, and with the severe level of medical legal issues, a lot of people do not want to touch preterm children. The strategies for screening is you need repeated follow-up, proper counseling, prolonged compliance forms, and follow the national guidelines. It is 34 weeks and less than 2 kg. And the most important, first screening in 20 to 30 days is essential. If the child is sick, please call somebody to your nursery and do it, because they are the highest children who cannot go to the office. So the first 20 30 days of life, the eye checkup is essential. And prevention is better than cure. We need to increase the manpower in screening, but there will never be enough ROP specialists to deal with the rising epidemic. So we may have to treat the paramedical to actually do screening with cameras. And laser treatment is still better than injections. And I think the most important thing is do a holistic treatment of the child and the nurse. Thank you.
Thank you, Dr. Amit. I think with your experience of so many years, you're able to compile all the important factors into 30 minutes. But for our neonatology and office-based pediatricians, it may be a little difficult to understand some of the concepts. So we have some time. So we can, some of the people were saying that it is a little fast presentation, but that may be your way of communication. So we can revise some of the points. So just for understanding of everybody, we are
I'll
saying
go back
that,
to the slides.
yeah. So no, it's all right. It's all right, Dr. Amit. There's no point going to the slide. We just emphasize 2 points. One is that you said that all babies who are born less than 2 kg and less than 34 weeks should be sent for ROP screening according to Rashtriya Bal Suraksha Swasthya Karyakram, RSB. Right. So that means all office-based pediatricians who are listening to me, it's possible that babies who are less than 2 kg, less than 34 weeks, may not have required much intensive care, and they will be followed up by you after first few days of life. And the first checkup is at 30 days of life. So make sure that you are advising them for the first examination at 30 days of life, despite not having intensive care. So that is first point, that all babies, irrespective of intensive care or non-intensive care, in our country, less than 34 weeks and less than 2 kg will require a ROP checkup. Is that correct, Dr. Amit?
Yes, absolutely. And if a child has been
And
sick
second is
beyond 34 weeks, that child can also need to be screened.
right. The second point is that even beyond 34 weeks, 34 to 36 weeks, when they are still premature, so any baby who requires intensive care and falling into this group will also require a ROP treatment. And that is also by our enough guidelines and also by RBSK guidelines, that intensive care required babies and between, but not full-term babies. So between 34 weeks and 36 weeks, 6 days, they become 37. And third point is RBSK also says, if a neonatologist feel that baby's course has been very eventful, even that baby ROP examination is desired.
Absolutely right.
So that is the first point, that we should not be erring on ignoring this. So we have made a template in our NICU. When all babies who go home, there's a template of ROP. We are right in the discharge summary also, ROP due on this date. So that absolves you from the medical legal responsibility also, that you have mentioned at the time of the discharge that this baby requires ROP on this date, this time, with this doctor after this appointment. And then every checkup baby comes for us, any one of us, we ensure it again that yes, your baby's ROP is due on this date. So that is point number 1. And now point number 2 is that babies who are less than 34 weeks and who remain in NICU for long period of time, we should not forget that their survival is important, but at the same time, ROP examination has to continue. So we do our first checkup at 4 weeks, and then depending on the need, the Dr. Amit and his team will guide us when the examination is due next. Sometime it may be after 3 days when you feel that the ROP is progressing very fast. Sometime it can be at 1 week and 2 weeks also. So what we have done is that we have made a WhatsApp group in which every resident is part of that group. As soon as the resident examines the baby, at the same time, it may be any time of the day, he will write that ROP of this baby is due on this date. So by the end of the day, the ophthalmologist, Dr. Amit and his team will look into all the messages which are due for that day. And then we are not in that situation that somebody misses. It's your memories, it may fail you, but then the examination is done on day-to-day basis. That logistics has helped Dr. Amit in our follow-ups, in ROP checkups. Dr. Amit, you are there?
Yeah, I'm there.
Right. So, since we have made that WhatsApp group and information is coming more readily to the team, does that ensure that your all checkups are done in time?
Yeah. So it's important to give time and date to the patient, then saying get an eye checkup done after 2 weeks. If it's
Right.
labeled, yeah, at the time and date, the parents are much more. And if the child doesn't come, and sometimes the patients will come to the pediatrician, not to the ophthalmologist. The pediatrician again reinforces, know that you need eye checkup. So the parents are going to listen to the pediatrician much more than the ophthalmologist. So please always check a child before 40 weeks. Let the child have the eye checkup to see the prescription of the ophthalmologist.
Right. And eye checkup also is something which is now eye checkup, laser, they're all being done in NICU. So, Dr. Amit, will you tell us your experience of doing ROP examinations and laser also in NICU? Is the shifting to OT is compulsory, or you're comfortable doing these checkups
The,
and laser in NICU?
so checkup can be done in the any warm area. So child has to be kept sterile area, and we should not pass the infection, any infection from us to the child. So we wash our hand like surgery, we wear gloves, and we use autoclaved instruments, speculum. So it's important that the you have adequate amount. If you're going to a nursery and you have 5 patients and 3 speculums, you will not be able to sterilize it. You must have the ophthalmologist should have adequate set. A lot of hospitals have found that they are just cleaning with spirit or the speculum has to be cleaned before examining. So the ophthalmologist should have a set of instruments. And if you have a busy nursery, I recommend the pediatrician to keep all the equipment for the ophthalmologist in their nursery.
But even the laser therapy, it's okay to be done in NICU, or maybe for peripheral centers, you advise them to be in OT only?
No, it can be done in the nursery. You can do without sedation. If the child is big enough and the child is uncooperative, a mild sedation would be required. It is the comfort level of the pediatrician whether they can manage the sedation in these. So what we do is 90% of children we do not sedate. We just put local anesthetic drop, uh, keep the child nil only for 2 hours. We put a IV line, monitor it with pulse oximeter and ECG electrode because sometimes the child cries and moves and the pulse oximeter shifts. So ECG electrodes help us monitor the heart rate better. Whenever the child has pain, the child will have tachycardia. So this ophthalmologist has to stop doing the laser at the time of tachycardia, let the child become comfortable. So the pediatrician has to decide that between this heart rate or if the child has pain, the child will go into apneic smells and the heart rate will drop. So for the ophthalmologist needs to know that both tachycardia and apnea are going to happen during and should not panic and stop the procedure for some time so the child becomes comfortable. So the pediatrician can also put a sucrose cotton in the mouth for the child to be comfortable, or you can put some sedation or analgesia to the child for the child is comfortable. So if the zone 2 or 3 is there, then less laser spots need to be given and you can do it faster. For zone 1, we don't do laser as primary, we give injection. Injections should be given in a sterile environment. Nursery may not be a complete sterile environment and does not have a microscope. So normally when we enter the vitreous in an adult, we enter at about 3.5 millimeters or 4 millimeters from the corneal margin. That is called the limbus. In preterm, the ciliary body is not developed. We do it at 1 millimeter. To measure that 1 millimeter from the limbus, you need a microscope. So in the West, sometimes they say that the child cannot be transported to the OT and then please put the injection in the nursery. But then you need a good loop or magnification to see that measure that 1 millimeter. If the needle goes at an angle, you can create a cataract while giving the injection. So remember that the injections is becoming very popular, but if the child's vitreous gets infected during the injection, then you have lost the eye. So injections are uh, going into the eye, while laser it's not a not going into the eye. So the risk of infection or severe complication is not there. While in an injection, if the child moves, you may injure the lens, and if you are not, the environment is not sterile, you will cause an endophthalmitis. That means a sure shot loss of vision. And thirdly, if you were to give an injection late, so 32 to 36 weeks is the best time for injection. After 36 weeks, fibrous membranes start forming on the retina. That time, if you give after laser, if you're giving late injection, you will cause a retinal detachment, but due to the injection, because the injection causes fibrosis. If the fibrous membrane is formed, you will have a fibrous proliferation and detachment. So we have to be very clear that the injections need to be given in the OT, definitely in the OT.
There was some controversy regarding the approvals of the injections. So you feel that all those obstructions have been removed and
So first, there was a BEAT trial. So BEAT trial used Avastin and bevacizumab. Bevacizumab is an anti-cancer drug. The same company made Avastin and ranibizumab, and they did not want to sell bevacizumab for eye. They never took a FDA clearance for eye use. But still, bevacizumab is the highest used drug in the world. The same company, ranibizumab, they did a trial which has been approved worldwide. So now, with the coming of that Rainbow trial, it has become definitely that there are limited side effects and it is effective. You can use both ranibizumab and bevacizumab. Both can be used. We have trials that will show that the efficacy. So injection works wonders. The ROP stops in within 24 to 48 hours. It starts regressing within a week. But at 4 weeks, it will come back. So it's important to follow up these children. Those with laser patient, once the RP regresses, it is never going to come back. So it's important that children who are given injections, say given at 32 weeks, will require follow-up at till 40 weeks. And after 4 weeks, the disease may come back. So there are two schools of thought. One which say follow up the child, and at 55 weeks, if there's not complete vaccination, then do the laser. But at 55 weeks, you will require general anesthesia to do the laser. So there's only one hospital in India which is doing this, which is PGI Chandigarh. They do sedation and general anesthesia to give laser at 55 weeks. The number of lasers are less, but the remaining country feels that GA is too high risk for a newborn and the facility is not there. So whenever the ROP recurs or the child crosses for around 40 weeks, please laser all these children. So we cannot follow up these children. But they need about 10 visits after injection, which is not practical in India. So do the laser with the injection once the zone 3 starts to get vascularized. So you have limited side effects of laser.
So this is very clear that injection is has to be followed up a long time, and there will always be a need of most of the babies may still need a laser at a stage. So that should be mentioned when we are giving this offer to the patient that baby needs an injection at that stage.
Absolutely.
Dr. Amit, what is the cost of this injection and cost of laser therapy in private setup?
So laser therapy, the cost of the nursery plus the laser. So the pan-retinal photocoagulation per eye can cost from 5 to 20,000 per eye.
And in the injection?
Injection, if you have a bevacizumab, Avastin, then it's a vial of about 30,000, which is shared among 5 patients. So if the hospital has high volume patient, but majority of the hospital has stopped using it, they use ranibizumab. So ranibizumab injection comes for about 10,000 plus. The Indian one, and the imported one comes for 20,000 plus the procedure cost.
So in today's era, we have two therapies only: laser and injection. Injection for aggressive ROP initial phase, and then it will be followed by laser.
So what we can promote is we are promoting two things. We have laser only or laser plus injection, but we do not promote only injection.
Right, that is true.
I can't hear you. Can you repeat? I can't hear you.
Gone out of the now. The growth now, there's no role in cryo.
Pardon?
Cryotherapy has no role in current day management?
No, cryotherapy requires general anesthesia. It has no role.
No role currently, right?
No role current.
Right, right. So now I'll take some of the questions which the attendees have posted. So Dr. Anupam Sharma wants to ask, do we need to assess vision in babies with documented hypoglycemia?
No, that is the brain. The hypoglycemia will cause brain damage. So if there is a hypoglycemic damage to the brain and the patient is follow-up, has convulsions, then the eye evaluation for a cortical visual impairment needs to be done.
Right. So more of a VP type of issue and maybe MRI to see whether there's a defect in the occipital area. So
Yes.
Dr. Anupam again wants to ask when to do first ROP screening in babies less than 28 weeks, 2 or 3 weeks.
So if the child is having 4 weeks is 28 days is ideal. Generally, you will not have a rush disease. If the child has a very bad course, is on a ventilator, then in 3 weeks you can do it. Unlikely you will have a rush disease in 2 weeks of time. Until you have given them full oxygen, blood, infection, sepsis, everything is there, then only you will have in 2 weeks. Rarely you will have it. 3 weeks is the ideal time for a child, 3 to 4 weeks.
So I think we can take 4 weeks as a general rule, but less than 28 weeks, the course is normally very stormy,
Yeah.
and we may add 3 weeks.
3
But
weeks,
2
right.
weeks is good anyways.
2 weeks is not
How,
required.
yeah, how early should we do ROP screening? I think we already said Dr. Ritu wants to ask 4 weeks usually and less than 28 weeks, 3 weeks. The course is very stormy.
Yeah.
Dr. G. Daya wants to ask, is it less than 34 weeks or less than 36 weeks?
So 34 weeks and 2 kg, or a child with 34 to 36 who has a stormy course. In the West, it is 1.2 kg and 34 weeks. Unfortunately, the children which we are screening have IUGR also. So the weight may be to 34 weeks, but rarely in a good nursery, rarely you will find ROP beyond 32 weeks. So if you are having ROP at 34 or beyond 32, you need to reevaluate your nursery's best practices.
Absolutely, absolutely correct. So Dr. A. Jalil Ahmed wants to ask any comment on eye blinking in preschoolers. Is it normal or stress related?
So blinking depends on the many things, but dryness is the commonest, allergies and dryness. The eye has to blink frequently to wet the eye. So if you're in an air-conditioned environment, heated environment, mobile phone, allergies, spring catarrh, they all will cause dryness and will cause frequent blinking.
So some teardrops will need to be...
Yeah, teardrops and anti-allergy if there's allergy, spring catarrh or something.
Dr.
So
Anita,
all the children who have allergies and dryness should be evaluated for refractive errors.
Right, right. So refractive errors is on card for that reason. Dr. Anita Pandit wants to ask, who are the candidates who need CVI checkup? What specific investigations can be done to detect CVI?
So all children with delayed milestones, all children with cerebral palsy, hydrocephalus, genetic diseases will require vision assessment, where the fixation is not coming at 3 months, 3 to 4 months, or is not able to any complaint of poor vision. So all patients with neurological problems, preterm children, cerebral palsy, basically the neurological issues. So neurologists will take a call if they feel that the vision is not normal. So all convulsions, less than 1 year, all hydrocephalus, all preterm, all cerebral palsies should have eye evaluation. So eye evaluation is part of all developmental clinics. Because we can pick up, you remember that to read a line, so we have two eye movement called pursuit and saccade. A saccade is a rapid right to left eye movement, right? And a pursuit is when you're following somebody. That is a pursuit is a slower movement. One comes from the frontal lobe, one comes from the parietal lobe. Now, if I'm reading a line, I'm pursuing the letters from left to right. And I go to the next line, I need to do a rapid saccade and come to the next line and then pursue that line till the end. So remember, to read two lines, I require two lobes to be functional. So 40% of the brain will be used to assess a photograph. So we can give a clue that yes, the patient may have absolutely normal retina, no optic nerve atrophy, but still is not able to read, is not able to follow, is not able to walk. So the visual assessment in these children is important. Sometimes we tell the pediatrician, please get an MRI done. We feel that the child is having a CVI. All strabismus children should be sent to the ophthalmologist. So preterm genetic diseases, hydrocephalus, neurological problems, developmental delays should be sent to the ophthalmologist.
Correct. So that also answers the question from Dr. B.R. Gupta, who wants to say that injection will be relevant to neonatologist, but some general practical guidelines, which is what we are discussing, that we have to take care of a lot of cerebral palsy, patient developmental delay, prematures who come to office-based pediatrician follow-up. So not only ROP checkups, which is mandatorily our responsibility as well as a medical legal compulsion, we also need to refer these patients of other issues of developmental delays to a eye specialist for examination, because then we need to be sure that their vision is all right. Dr. Padamja wants to ask, red eye reflex can be done by pediatrician?
Yes, using the ophthalmoscope.
I think if you look at the new program of the government of Delhi as well as the RBSK program, it mandates that all babies before discharge from the hospital should be done a red eye reflex. So we are doing it routinely for all our babies. So you don't need much. You just need a direct ophthalmoscope, be around 30 centimeter from the baby, and look into the baby's eye. And if you just look with the red eye reflex on both the sides, document and send the baby. So that is mandatorily done by pediatrician. Actually, it is done by pediatrician only. Eye checkups done by ophthalmologists, they can do much more than just a red eye reflex. Dr. Atif wants to ask, do we need to assess 2 kg 36 weeks old normal newborn?
No, you don't need to evaluate the child.
Right, less
Standard
than 2.
ophthalmoscope for any congenital anomaly is fine, but not for ROP screen.
Right. Dr. Padamja wants to ask, can you please explain CVI again?
Sure.
Few words. Huh?
Yeah, CVI is cortical visual impairment.
Right. So basically, we are saying the brain is not seeing anything.
Yeah. So we require the occipital cortex evaluates the image. Right? Yes.
Correct.
It is like a printer. It prints the photograph. Then the posterior parietal lobe maps it, gives a 3D dimension to it. The color, the 3D image. And the temporal lobe will identify it. What is it? For me, a child who cannot recognize, we use the preferential looking test. We have graded lines and photographs to see the image. So a small child cannot have a recognition vision. So this normal vision chart, what we call the sternal visual chart, is a recognition chart, which will come after 3 to 5 years. In a small child, we just show images, and seeing the fixation of the eye, we have assessment of the vision. So we cannot assess a child less than 3 years compared to adult vision. So many parents ask us, is the vision normal? We tell them that the brain has all these software. Like the pediatrician says, 1 to walk, 2 to talk. You're born with all the software, but the brain has to unleash that software. It is the timing to unleash the software. So the brain is going to unleash various softwares which will help assess the vision. The vision is not in the eye, the vision is in the brain. The software is analyzing the image. So the occipital cortex it just takes the image, the vision. Then you have to have a 3D. So if I am seeing a video, a person walking is like a video. It is a photograph in multiple time dimensions. If I have to see you walking from step 1 to step 10 of a stairs, then I need every second photograph to be analyzed. I need a 3D video to be created in my brain to evaluate somebody walking. So that is the parietal lobe is going to map it up. Then identification is going to come from the temporal lobe. So if your occipital is not working, you'll have a loss of vision. But the others will not have vision loss. They will have coordination issue. You cannot integrate your vision with your vestibular system, with your touch. So you need all three. After all, a blind person can walk straight, doesn't require vision to walk. The vestibular system creates a balance of vision. But you require all three to create a balance and have a 3D mapping.
So correct. Seeing and vision is not same. So that is what is a tagline. You can see by eyes, but your vision is through eye and brain. So that
Yes.
is, you must remember once you discuss CDI. Dr.
Yeah.
Jaleel Ahmed wants to ask, what is the red flag sign in ROP during NICU stay in NI for newborns? Any red flag?
Yeah. So if the child is on oxygen, is on the ventilator, has sepsis, and you given blood transfusion, and the first 48 hours was in a small nursery which didn't have pulse oximeters, gave unbridled oxygen, didn't have a CPAP or a BiPAP machine. The first 48 hours history is more important. So when I see a child in the nursery, I divide into two groups: inborn, outborn. An outborn may not have the same quality of care in the first 48 hours which my hospital gives. So inborn and outborn will have different results. The first 48 hours, what was the care? Does the child is still on oxygen, is still on ventilator, has sepsis? All these are high risk factors. Intraventricular hemorrhage, all these are high risk to RO.
And another very important red flag is that non-dilatation of pupil
Pupil.
once you put a drop. And if the pupils don't dilate, don't leave the baby. This baby is at higher risk of developing advanced ROP. So make sure that that baby definitely is examined by an ophthalmologist. Dr. Sukhdeep Kaur wants to ask any complication of the procedure. I think she's asking the procedure laser and injection.
Okay. So
Complication.
when we do laser, the laser we are pressing the eye. So post-operatively, there will be lid edema. There will be some ecchymosis. The conjunctiva may have small hemorrhages where we have pressed the eye. So the parents have to be warned that the lid will be swollen and there will be small hemorrhage on the surface. On the inside the eye, the laser, if you do aggressive laser, you may have a swelling on the choroid in the retina called a choroidal detachment, which is very rare. You may have small hemorrhages, but laser itself is causing long-term peripheral vision loss, which is not very significant. Children who are lasered will have a higher risk of myopia because the eye length growth, the anterior segment and the posterior segment growth are altered in all preterm and more with laser. So the risk of myopia goes up when you treat these patients. So when they go on the net, the parents think that laser is more destructive than the injection because it is written that it causes myopia and peripheral vision loss. So they are not agreeable for laser, while laser is actually safer because the injection itself can cause immediate blindness by infection and retinal detachment. So in my view, injection is more dangerous than the laser. Laser is non-invasive, while injection is invasive. Any invasive procedure will cause more complication.
So we are very clear on this that though the current practice of using injection is increasing, but laser is safer, laser is non-invasive, laser is required anyways, even after the injection has been given. Injection is just a short gap arrangement for aggressive ROP and just to curtail the disease and just to make sure that the vision, as far as possible, it does not become very narrow, very tubular. It still have some retina intact with the help of injection, and later on laser will be still required. So laser is going to stay for ROP management, and injection will be there for selective patients in selective settings with a possibility of a long-term follow-up. I think we have some time. If somebody, some of the delegate wants to ask questions directly, they can raise the hand. I can upgrade them to panelist link, and they will be able to ask question directly also. So we were, Dr. Amit was very patient in answering all the questions to the full possible, and he has made it very simple for all of us to understand that ultimately it is a combined responsibility of a neonatologist, pediatrician, and ophthalmologist to send these patients for checkup, and not only ROP. They need to be examined till the time their vision is complete. They start going to school. They are start studying well, and their academic performance is all right. Because many of those issues can be hampered by altered visual development.
Atif
So
wants
I
to
can,
ask something.
yeah. Somebody want to ask? Yeah, there are more questions. I think
Atif,
there's one. Dr. Satish Bansal wants to ask the success rate of laser therapy.
so laser will work if done at the right time. 99% will regress with laser zone 1 and 2. So if I go back to the ROP study initially, zone 2 disease, 85 to 90% will regress with single laser. While zone 1, if only laser is there, 50% will regress. That's why injection has come in. So depending on the zone, the prognosis is there. But with proper treatment now, if you are aggressive enough, you can save 100% of the eyes from going to stage 4 if a regular follow-up is done and the timing of the treatment is done. For many years, we have not let any of our patients go to stage 4.
Right. I think since the time this combined therapy has come, no baby I remember in last, I think at least 8 to 10 years, no baby has gone blind in our NICU. Dr. Amit Suwail wants to ask, post ROP, which antibiotic eye drop needs to be instilled and for how long?
Okay. So any intraocular injection, we normally disinfect the conjunctiva with betadine. So it has become a standard practice in all conjunctivas, whether you do any surgery in the eye, with 5% betadine, we lavage the conjunctiva, so all the flora is killed. So most important, what we have found across the world is whether you give antibiotic post-op or not, at the time of the injection, the conjunctiva has to be made free of bacteria, and betadine is the best way. No antibiotic will kill as much as betadine will kill. So we use any antibiotic drop because the port opening is a 30 gauge needle we inject. Even if you give no antibiotic, it's not going to have any problem. But yes, we do give, and quinolones are not recommended for children. So we use tobramycin. Though if you see literature, some people will find that even tobramycin is not safe in children, but tobramycin is safer than any quinolone drop in children because there is uh, a rider in the literature that quinolone should be avoided in young children.
Right. So with that, we are in 1 hour plus into this session, and we have answered all the questions, and nobody has raised hand. So it gives me.
But Dr. Atif has raised that.
Yeah, somebody has raised. So yes, yes. I just do it.
So Dr. Jaleel Ahmed has
Atif,
asked,
you have been.
yeah. So in a peripheral setup or resource limited setup, can we use ordinary light source for what? We need an intraophthalmoscope for evaluation. So an intraophthalmoscope can come as low as 40,000 rupees, Indian ophthalmoscope, and a lens for 20,000. Since 60,000 rupees, you can have a complete, and any eye surgeon would have this setup. So you can call any eye surgeon to come and do a ROP screen.
Right.
Dr. Atif, yeah, he's
So,
online. Dr. Atif, please ask a question.
I have
Excuse me,
upgraded
sir.
Atif. So Atif, yes,
Sir,
Atif.
my question is,
Yes.
if there is a 36 weeks old full-term male, and if the child is having slight cessation of breathing and a slight resuscitation is started on him, will the child need to have ROP in the future? ROP done in the future?
No. See, ROP will occur before 40 weeks of gestation. If you're seeing a 36-year-old child, at 40 weeks, you require a checkup, right? So, unlike
No,
by
sir,
40,
a full term,
no,
38,
ROP will
39 weeks old
no,
child
no, no, ROP will
having.
not develop in ROP will not develop in this such children.
Oh, yes, sir.
Okay.
By 38 to 39 weeks, normal vasculation has occurred.
Excuse me, sir.
Premature babies. So till the time vascularization of retina is not complete, after vascularization of retina is complete, whatever intensive care baby may require, ROP will not develop.
Okay, sir. But retinal detachment can occur sometimes if we resuscitate and oxygen.
Retinal detachment may be other causes. Other causes of retinal disease may cause retinal detachment.
Yes. Then what we will call that test if we want an ROP to be done by the ophthalmologist? What we call that test?
ROP screening with indirect ophthalmoscopy. ROP screening with indirect ophthalmoscopy.
Okay, sir.
Okay, thank you, Dr. Atif.
Thank you very much.
Thank you.
So there a few more questions have come up, Dr. Amit. Will you be able to answer them?
Yeah.
I'll by one. So Dr. Salesh Singh wants to ask, if patient comes at 4 weeks or more, So you get a checkup.
So if patient does not come, we need to keep pushing the child. At least on the discharge slip, you should have had a checkup, and at least one checkup. Your staff should ring up all children. Please go and get an eye checkup done, and please share the prescription of the ophthalmologist with us so that the pediatrician will be legally safe. Once the child reaches an ophthalmologist, the onus comes on the ophthalmologist also. But till the first examination, it is the pure sole responsibility of the pediatrician. So please ring up those children who do not go for eye checkup. Please ring them up and ask them, please confirm with them that you have had an eye checkup.
So Dr. Jalil also wants to ask the same thing. What is the legal implication if we miss ROP screening?
So at the moment, the highest compensation given is 6 crore. And that to a government hospital, which was given in 6 crores because the child went abroad and the child was delivered in 90s when ROP screening was not there. That time a 6 crore compensation was given. So the highest compensation is being given for blind children. The court seems to have a extra sensitive dislike for doctors who let the child go blind. So a lot of ophthalmologists don't want to do ROP screening because the onus is on them.
So I want to answer this question by Dr. Rajesh. He is asking medical legal consequence if an institution not doing RP screening, even after pediatrician request. Dr. Rajesh, we must understand that once the pediatrician is saying this and the institution is not doing it, pediatrician is still not absolved from its responsibility. Its pediatrician has joined that institution voluntarily, and he has all the liberty to not be in that institution if that institution is not following medical legal issues, because nobody is above law. No institution, no pediatrician is above law. So it's a combined responsibility of institution as well as the pediatrician to make sure that ROP screening is done. And if you are at free will not to work in that institution, if that institution is not following ROP screening protocol, because still you will be held responsible, and you cannot be saved by saying that my institution does not do ROP screening. And we have ample examples with us from other specialties where the treating physician says that I had asked that institution to arrange for this. It was not arranged, so it's not my fault. Court always says you chose the institution, you can always change it, so you are not absolved from your responsibility.
You can send the child out for example. When the child gets discharged, you can send the child to eye check for eye check.
You can. So that comes to, I think there are no more questions, and Dr. Amit has been very, very patient in answering all the questions to the best possible extent. And I'm sure you will be able to listen to this talk again, because we'll be uploading this YouTube link in the group after 24 hours. So there any more clarification needed, and as some of the delegates were saying the presentation is fast, you can always look at this presentation again, and there's a lot of material in the slides as well as the talk, and you can upgrade and refresh your knowledge again. With these words, thank you again, Dr. Amit Khosla. Thank you for giving this responsibility.
Yeah, I think there's a last question which just come up.
Yeah.
So how feasible and fruitful are fundus cameras which can be used in periphery by nurses to screen ROP? Yes, ROP screening by camera is practical, but the cost is there. If the hospital can bear the cost, or you can tie up. There are about 10 cities where setups have had a mobile cameras which go from nursery to nursery. Yes, that also serves the purpose if you have a good retinal surgeon running that program.
Absolutely right. Okay, with these words, thank you so much. Thank you all delegates. Thank you, Dr. Amit, and thank you, Delhi IIP, for giving us this platform to update the knowledge of all office-based pediatricians. With this, have a nice Sunday. Enjoy yourself. Your academic session is over. 2 more sessions left, so don't forget to join again next Sunday, 4th, which is a session on respiratory distress in newborn, 9 o'clock. Dr. Sushma Nangia, current president NNF, is the speaker, and Dr. Satish Saluja, the HOD of Gangaram Hospital, is the moderator for next session. So all these